Thank you. Now we're going to go for a little while. We've got 15 minutes or so for some panel discussion. So we're happy to take questions. And what we'll do is we'll, if one can answer it, that's fine. But we might sort of bounce it along and get something. Sir, you're first.
Oh, g'day. Thank you very much for all the effort that's been put into this. This is fantastic. I didn't have $5,000 a month, sir, and I don't know how many other people here haven't got $5,000 a month, but I was sent to the Old People's Clinic, and I was told that I had existential difficulties about end-of-life issues. Yes! And then I was told maybe I've got 2 years to live. That 2 years was up last Thursday, Thursday before last. Yes. But I have spoken to people during the interlude, and I am quite willing to be treated as an experimental person to go on some of these stuff. And I've given them my hospital number, which is BEG 2834. How many times have I said that? All right? Now, I have been through the MRI. I've been through the scintigram. I'm in a vacuum. I haven't got $5,000, okay? Who's got $5,000 here a month? No, not very. It used to be when I was offered it was $5,000 a month. So that's the only problem here is that there's a political input or constriction on male prostate cancer patients. Or you wouldn't be a female prostate cancer patient, which...
Sir, I'm just going to stop you because we're going to get into...
Stop me there.
This is not a political rally.
No. Sorry, mate.
But what I do want to say is that we as an organisation, and I know people like Peter, are strong advocates for getting that particular and any similar drugs funded. We know that there's a limit to the health dollar and what Pharmac can spend. And the point you make about men's health as against some other areas of health is valid to a point. But we are doing what we can to the point where we have spoken personally with the Minister. We had the Minister speak at our national conference a month or so ago, and although he's retiring now, certainly his office and the Ministry of Health are very aware of our lobbying and our advocacy on behalf of that and other drugs that will come along inevitably and cost money. But your point is taken. Thank you for your little speech.
I'll just make a little note here that whilst it's the, abiraterone or Zytiga is costing $5,000 a month, at present Janssen has kindly set up a patient access scheme where you would be able to, in some ways, to put it bluntly, buy one, get one free deal, which does help a little bit. You need to talk to your oncologist about that. And I think, $2,500 a month, if you round it, average it out, is still a lot of money. The other point you made was, are you in limbo land? And I guess that's where, currently there is no standard of treatment for someone who has a rising PSA, but on scans there is no evidence of cancer. Now, scans aren't going to pick up anything that's, bigger than a centimeter cube, basically, and there's 1 billion cancer cells in there, 1 billion. So you can imagine why the PSA can go up. It's just a matter of time before we find out where it is. And there are trials at present, here or elsewhere, that look at addressing patients who fit into this limbo land situation where we have a PSA rise, and we just can't find the evidence of where the cancer is. And if there is no option for you to have local treatment to the prostate, and most of the time the cancer does not reside in the prostate, so treating the prostate to oblivion isn't going to help you either, then perhaps looking at something new and a different way of managing that might not be unreasonable. And if you look at what the Americans are doing, the Europeans, the UK, Australians, etc. There are trials trying to address this space where patients currently sit. So if there's other people who have a PSA failure, meaning a PSA rise without evidence of cancer spread, then that's something that could be looked at.
Okay, we've got a question? Madam.
I'd just like to ask Rea a couple of questions, and thank you for sharing your experiences with us. What is your PSA now? Are you allowed to share that? Because you said it went up to...
The PSA over time has gone up and down. Firstly, on the ADT treatment, it came right back down, almost to so-called normal. And after radiation therapy, it went back. With the chemo, and now abitrone, it's coming down, but it's still somewhere in the region of 10 or 15. But it hasn't gone back to normal, if you like.
And one thing you didn't tell us was the timing of the treatment. So I don't know when you started the docetaxel, and then how long it was between that and the Zytiga, because I can't pronounce the other word.
Yeah, sorry. The docetaxel I started in July, so it was 6 months to Christmas. So it was
Last year.
Yes, so 10 treatments, and then I started the Zytiga in February.
And something you mentioned that it did cost you $5,000 a month, and it doesn't now?
No, it doesn't. The scheme that Peter just alluded to came into being a couple of months ago. So,
But you're still paying?
two and a half a month. So you pay $5 up front, but you get the second month.
$5,055.
Yeah.
Thank you.
I'll make another point that the PSA is very useful at the beginning in early stage disease, but the PSA becomes less accurate as people's cancers progress. It's not to say it's useless. I think it's still quite useful, but it's not the only thing we look at, and that's because the cancer cells get smart. The signaling that's pegged to the PSA is uncoupled. So it's important that you look at your symptoms, how well you are, and look at some of the other scan evidence as to whether the cancer is getting better or worse, because you could get false readings that go either direction.
Sir.
Rea, I'd like to thank you so much because our experiences, there are many echoes. You've been dealing with it longer than me, but it was wonderful for me to hear you speak. And for those of you who are feeling perhaps apprehensive about the chemotherapy, I had 11 infusions of chemotherapy at 3 weekly intervals and came to regard it as my elixir. It was wonderfully helpful to me. I had few side effects. I started to lose hair for a little while, but as you can see, it didn't continue. And my granddaughter insists that it has to come down to here. I'm a very fortunate person because a very dear friend decided that she wanted to pay for me to start on the Zytiga. And I have. I'm 3 weeks into it. It's far too early to say whether it will be helpful. I don't know whether I'll be one of the people who responds to it. But I'm just sitting here feeling so privileged and fortunate to have that opportunity because I couldn't otherwise. And so I'm so admiring of the efforts of Peter and others to get the Zytiga accepted. Just to add to that, and Peter just alluded to Europe, I'm interested that in the past fortnight, I think, the British equivalent, sort of equivalent of Pharmac, had previously said no to Zytiga about 2 years ago. Then they said yes to Zytiga. And now they've caused a little consternation because they've said, yeah, well, yes to Zytiga, but you have to have had the chemotherapy program first. And of course, some people are too frail to have chemotherapy or for other reasons, or it's better to have the Zytiga sooner. But I'm interested that the Brits have at least taken Zytiga on board in a way in which we haven't yet. Thank you.
I think just for, Peter might correct me if I'm wrong, I think it's actually one of the other drugs that in the same sort of, is it the enzalutamide? Do you girls know, ladies know? Yeah, that you're referring to with the British situation. It's not the same situation? Right.
So abiraterone or Zytiga is funded in Australia after chemo, not before, and it's funded in the UK after chemo and not before. Enzalutamide is not funded anywhere at the moment, except through your own pocket, unfortunately. I mean, they're both very good drugs, mind you, and I guess I'm mindful this meeting is sponsored by Janssen, but I think, we live in a very difficult world, and everyone wants a slice of the pie, and the size of the pie in New Zealand is only a small pie, not a big pie. If we rob Peter to pay Paul and Mary, that becomes very difficult. I don't envy the job of our, legislators, etc. I don't think we have a right answer. Well, we'll just keep soldiering on.
I was at a conference recently talking to another health charity CEO, and they were lobbying Pharmac for a drug that is $200,000 per dose or something like that. So, there's some big money tied up in these, and as Peter says, you can understand they have to cut the pie up. Next question.
Can I just raise... It's on? Can you hear me now?
Yeah, we
Sorry.
can.
I just want to go back to sort of diagnosis and the early stages and what have you, and perhaps sort of raise issue with the medical profession in terms of the inconsistency in which GPs perhaps approach the subject. And Ross's statistics referred to the fact that there is some GPs in his area that are doing a lot more than others. And it would seem that there's still an element within the profession that has a lack of real concern regarding PSA levels in prostate cancer. I mean, I'll give you my example. I was feeling unwell for a period of probably 3 months with significant back pain, rare back pain. I didn't get a lot of support from my GP. In fact, when my GP was taking Fridays off, I went to see the person who was actually standing in for him. And at the end of the day, my PSA level was assessed at 900. He had actually been treating me with antibiotics and said I had slightly elevated PSA levels. Now, I mean, that seems, in terms of the numbers that Rea's spoken about and other people speak about, 900 is hugely significant. Yet, I got really no support from my GP. So, I mean, is there something within the medical profession that needs to happen to ensure that people aren't left out in the cold?
I think one of the things that is going on is that under this government there's been a prostate cancer task force, and as a result of that they've recommended a quality improvement program for the management of prostate cancer, and that's going to go all along the pathway. So very much we're looking at guidelines for GPs, we're looking at decision support tools both for patients and for GPs about how to approach different situations. And within our program, we have the man with no symptoms, should you have a PSA test or not, but also for the man with symptoms, including backache, what should be the pathway for that. So we are working on that. I think the other area that is really important is the use of anti-androgen deprivation therapy and then chemotherapy, and getting better guidelines for the monitoring and looking for castrate-resistant prostate cancer. So there is a quality insurance program that the ministry are working on, and very much part of that is about informing both general practitioners and making patients aware. And I think all GPs are very aware of Dr. Google, you know, and that patients are actually asking really important questions now and challenging the pathway.
I've got
Yes.
two parts to this question. The first one is aimed at Peter. Do you have any strong views on alternative therapies like acupuncture, herbs? I have lots of people coming to me and they ask, and you have to go back and ask the oncologist. So is there anything particular that you sort of think, oh, you go try, or do you think, no, you shouldn't be taking this with this, or what's the advice we should be giving people?
How much time have you got?
About 2 minutes.
I think it's difficult. I mean, there are therapies that have come to the forefront and shown to be useful and may have come from, you know, something that has been used for 5,000 years, and, you know, Grandma so-and-so said it was good for cancer, and someone managed to find, you know, there was an active ingredient in there and it turned out to be something useful. But until that, I guess, you know, baptism by proof is there, it's very difficult for me to recommend. The other thing about alternative therapy is that one recommendation of alternative therapy in Auckland is different from one in Rotorua, which is different from the one in the UK or US or Eastern Europe, no matter what you do. So I guess, you know, you can go, the patient can go chasing a lot of things. And I think that detracts from what we're supposed to do, which is, you know, on the one hand, you know, you may say that's hope, etc. On the other hand, I think, you know, he has to deal with it now and then. So drug treatment, I think it's going to be difficult. Drug treatment, I think, is going to be difficult to combine with alternative treatments because we don't really know what's in the air. And if the drug treatment has what I call a narrow therapeutic window, meaning that if there's any little bit that is going to upset the balance, then not being on something is not being on something else that's going to muddy the waters will be much easier for me to determine whether someone's actually having side effects from the chemotherapy or not. So I would say that I would prefer that some of these things that you ingest or inject into yourself are not used. People who go for acupuncture, I don't think there's any major problems with that. Just go to a reputable practitioner who uses, you know, sterile needles, etc. I guess there's no real right or wrong answer. On the one hand, I can understand the motive for the patient to do that, and on the other hand, there's, you know, possibility for things to go wrong, and I guess alternative therapies can sometimes cost quite a lot at a time when, you know, the patient needs to be aware what he truly wants to, you know, use his money for, which it may not be for expensive drugs like IGO, but it might be for, you know, the family, where it's more important for them, things like that.
The second part of my question was, there's lots of research now about exercise through all stages of cancer, not just for pelvic floor exercises to help with incontinence issues. How is that being addressed through the foundation, or how is that sort of being pushed to Joe Public? Because I get people coming along and they have no idea why the urologist sent them to a physio. And, you know, this should be maybe information that's going in that initial pack that they receive, that there is help out there to help with quality of life, you know, post-surgery or during chemo, during radiotherapy, and how important it is. I mean, what can we do about that?
You're directing that to me?
Possibly you.
Yeah, I think we don't have any formal information on that or recommendations on that, but certainly through our support groups and things like that, we make those sort of speakers available. You know, people like yourselves, we're very keen to form relationships with and have information available on websites and things like that, and encourage it. But I think, you know, we're a backup service in that regard. It really comes down to the clinicians and the people in the medical profession who are dealing with them to highlight those areas as well. We're just going to take a couple more questions because we're really out of time and we need to let these good people go. So, Dennis, you've got one.
Hi, my name is Dennis Terry. I'm the West Auckland Sport Coordinator. Just on the line of the alternative treatments, had a guy come to my meetings who had just been diagnosed and didn't want to go down the usual route of conventional treatment. He went through high-dose vitamin C injections, and from that point learnt about St Benedict's Clinic doing an immune boost treatment, which he decided to take part in. The short story is 2.5 years later, he's almost clear of prostate cancer, and that's the only treatment he's had. Is anybody would like to sort of comment on that?
I'll leave that to Peter.
Based on the information you've given me, it is impossible to comment.
Yeah.
That's all I have to comment on, I'm afraid, because I say this one thing. It sounds great, and I'm very happy for the patient. I'm not sure whether there's enough medical and scientific information in here to make a valid comment.
I'll give you more details if you want.
Thirdly, that is one success. What is the denominator of other patients who have been through the same treatment? And what successes have they experienced themselves? I guess I would look at things with, an open mind. Yeah, that's about all I can say at this point.
Thank you, Peter. Was there another question here somewhere?
No, it was the same one.
All right, same question.
Yep.
You'll be the last then.
Thank you.
Thank you.
I'd just like to comment on my husband's cancer. We've gone through the Waikato system and we can't fault that. Trevor's just finished has just been taken off chemotherapy because it's no longer seems to be working. So we're waiting in anticipation of the other drug as we can't afford $5,000 a month. My question is, so I have a 28-year-old son. At what age should I be getting him to have his PSA?
Good question. Thank you.
I hesitate.
This is in GP territory.
This is very controversial. I mean, I don't think there is a lot of data. I mean, I think the USAND would say at 40 it's useful to have a PSA done. And then depending on the result of that, how often you have your PSA done after that. But with a family history and a strong family history, that is high risk. And certainly you should have that discussion with your GP at 40. I think before 40, most GPs would say the evidence is that even with a family history, the likelihood of picking anything up is minimal. But doing a PSA at 40, if it's very low, then that's a really good prognostic indicator of the future. If it's slightly raised, then it's an indication that you should be monitored more frequently.
It would be most probably useful to reflect on one of my sons, because I've had the very same question that you've just raised. I've got twin sons that are 36 and my oldest is 41. And the father of my grandson that I was talking about, he is a recovering drug addict, so he's been on heavy drugs for over 20 years and he's been off them now and self-managed himself for the last 3.5 years. Now, he's followed this journey, and I have to say my diagnosis was one of the turning points for him. And so to get him right, get back to the GP because, he's a real big boy and cholesterol and all of that sort of stuff. Let's get on to, an annual plan and so on. So he went to the GP. I said, talk about the PSA. So he raised that question. He's 36 and he raised that with the GP about, GP had no problem, just doing all the tests, diabetes and cholesterol and so on. He would not do the prostate. He would not do the PSA. And they got into an argument. And unfortunately, my son's social skills deteriorate after about 30 seconds. And he insisted, but the GP against his advice is, no, we'd be around about 40. And he also knew that there was a history with myself and my father and so on, but the GP just said, no, round about that 40, so he's done it. So, but that's going to have to be around that discussion of when that comes back. It's come back, in inverted commas, normal, but he didn't tell him what it was.
Okay, I would just like to wrap things up now. And so firstly, I want to say thank you to our speakers, and Andrew in absentia, giving up their time today for most informative presentations. Please join me in thanking them again. I would also like to thank again Janssen for the support, and please understand this is not we've not been trying to promote a particular drug that's been talked about a little bit. That's not been the purpose of this event at all, but we want to thank them for their support for these forums, because they've in fact made it possible. So thank you. I also want, as I look around the room here, I also see some people who have done some special things for us, and I don't want to pick everybody out, and I'm in danger of missing people out, but there are some people here. Tony, wave your hand, Tony. Tony rode a bicycle from London to Valencia in Spain and raised a whole heap of money for us about this time last year. Regardless of his condition, and he's still cycling, so that's great. Phil over here, a number of you are here because you saw him on telly on the news program the other night, and it's not easy to go and tell your personal story in front of national media. So Phil, and Gail too, for the support you give. We've just sort of picked him out of the box, and he hasn't done anything famous or anything. So he's just a good Kiwi bloke that we roped in. Our support group coordinators and other volunteers who are here too, we really appreciate what you do. So thank you all for coming. I hope that this has been very worthwhile for you as you are various stages along your prostate cancer journey. And we do really wish you well. If there's anything we as the Foundation can do to assist, support, provide information, anything like that, please be in touch with us. And again, if you want some of our brochures, newsletters, and blue ribbons on the way out, you can pick those up. So again, thank you very much for coming. It's been good to share the afternoon with you.